Assalamu alaikum. This is Dr. Shereen Meshaly. Our topic is about one of the most common bone disorders among adult populations, which is osteoporosis. After this lecture, you will be able to identify what's osteoporosis, recognize the pathophysiology, risk factors, and the clinical presentation of osteoporosis, and know how to assess for the bone mineral density and to diagnose the osteoporosis, and how to treat and manage osteoporosis, aiming to prevent fractures. So what's osteoporosis? Osteoporosis characterized by low bone mass, microarchitecture deterioration, which will lead to compromised bone strength and eventually end in increased risk for fractures. However, osteoporosis is a silent disease. It's a symptomatic disease, may be complicated by fractures. Maybe the first presentation is fractures, pathological fractures, even with no trauma, or a traumatic fractures. And as we said before, it's the most common bone disease in humans. So, what's the definition of osteoporosis? Osteoporosis is a bone disorder characterized by low bone mass and microarchitecture disruption causing weakening of bone, which predispose to fractures. The human skeleton is composed of 20% trabecular bone and 80% cortical bone. The trabecular bone is a metabolically active part of the bone which undergoes bone resorption and formation. About 10% of the adult skeleton is remodeled per year because the bone undergoes a continual process of resorption and formation during life. That's called bone remodeling. In the resting phase, the bone surface is covered by a protective layer of bone cells, which is called the lining cells. During resorption, the osteoclasts, which are cells which will invade the bone surface and erode it, including the minerals and the matrix. And after resorption completes, a small cavity is created in the bone surface. Then the formation phase will start. Formation of new bone formation and repair or healing of the bone occurs by the bone forming cells, which called the osteoclasts, will fill this gap or this cavity with new bone. When this filling is complete, the repair is complete, and the bone surface is completely restored. This is called the bone remodeling, which continually occurs during life, which is a process of resorption and formation. When there is imbalance between the process of resorption and the process of formation, imbalance between the rate of resorption and formation and reformation, a reversible bone loss will occur as a result. This usually occurs at the areas where there is more than 50% of the trabecular bone, and this imbalance between the rate of bone formation and bone loss occur particularly in situations of increased bone turnover, for example after menopause, and usually this is due to loss of the effect of the estrogen on the bone, the anabolic effect of estrogen on the bone due to estrogen deficiency. Usually these sites occur at the vertebral bodies and the neck of the femur and the distal forearm. Here is the picture of the normal healthy bone, and to the left, and we have the picture of the osteoporotic bone. We have the normal healthy bone with this strong compact bone, strong cortical compact bone outside, and inside we have the spongy bone, which is the metabolically active one. And to the right we have thinning of the spongy bone with wide pores and loss of the trabecular network or mesh of the bone, and weak thin compact bone outside. bone mass can keep growing until the age of the late 20s. At this point, bones have reached their maximum strength and density, which is the peak bone mass. So usually we reach our peak bone mass between the age of 25 and 30. After that age, the bone starts to decline. So what's the effect of aging on osteoporosis or on the bone? Elderly females usually, due to decreasing the effect of estrogen and losing the estrogen, tend to show widget upper vertebra and the crushed lower ones. So the woman starts to decrease in height due to this wedging of the vertebra, and with advancing the age we start to decrease in our height. This is again the picture of the osteoporosis. To the left and to the right we have the normal picture of the bone. What are the risk factors of osteoporosis? We have a non-modifiable that cannot be corrected, and we have a modifiable risk factors. Among the non-modifiable risk factors, of course, increasing age, ethnicity. Some races are more prone to develop or get osteoporosis than the others. For example, the Caucasian are more prone than Asians, who are more prone than African Americans to develop osteoporosis. Family history of fractures. One of the parents, especially mother, have previous fractures, this will carry more risk for developing osteoporosis. And if the patient have some uncontrolled severe diseases like rheumatoid arthritis. And on the other hand, we have the modifiable risk factors, which can be modified or corrected, like the low body mass index, less than 58 kilogram body weight, sex hormones, of course, deficiency of estrogen or testosterone will predispose to osteoporosis, low dietary intake of calcium and vitamin D, the sedentary and inactive lifestyle without any physical activity or exercising, excessive intake of alcohol beverages, excessive coffee and soft drinks, heavy cigarette smoking, some diseases like hyperparathyroidism, either primary or secondary, and hyperthyroidism, some GIT conditions which impair the adequate nutrition of the proper nutrients for and the proper absorption of calcium and vitamins, some drugs, and we will discuss later, like steroids, or if you have Cushing's disease, and some drugs like proton pump inhibitors. Some other medical conditions associated with increased risks of osteoporosis, like the COPD, the malabsorption, as we said before, the Cushing's, the hyperthyroidism, thyrotoxicosis, and hyperparathyroidism, other autoimmune diseases like the rheumatoid arthritis and other connective tissue disease, inflammatory bowel syndrome, some psychiatric disorders like the anorexia nervosa and depression. If we have hypophosphatemia, vitamin D deficiency, some malignancies like multiple myelomas, strokes, insulin-dependent diabetes, liver and kidney diseases, and some bone diseases like osteogenesis imperfecta. It's not an inclusive list, but it's some examples of the diseases that are associated with increased risk of osteoporosis. The drugs that are associated with reduced bone mass, among them the most important is the glucocorticoids or the steroids intake, whether oral or parenteral, or inhaled doses of corticosteroids, especially for long periods, more than 3 months duration, and even the lower doses lower to 5 milligram or more per day, but for longer periods will predispose for osteoporosis. So it's very important to ask your patient in the history about the history or the current intake of steroids. The other drugs include the heavy metals like lithium and aluminum, some of the anticonvulsant drugs because they inhibit vitamin D metabolism, some cytotoxic and immunosuppressive drugs, and the heparin drugs, especially for chronic users, the excess thyroid replacement because it keeps towards the upper end of normal, and the gonadotropin releasing hormones. That's not an inclusive list, but these are some of the drugs that can cause or predispose to osteoporosis, but they are not all. Factors associated with bone loss in men. We have genetic factors, and among the most important of them is the hypogonadism, which is the best characterized risk factor for osteoporosis and osteoporotic fractures. Other risk factors are the same as in women, like excessive smoking, alcohol intake, low dietary and calcium and vitamin D intake, sedentary life, and low physical activity and strength. So the most important is this hormonal disturbance, decreased testosterone production or increased estrogen production, and hypogonadism. What are the clinical findings of osteoporosis? Generally, as we said before in the introduction, osteoporosis is a symptomatic disease. Even with very low bone density, the patient may be completely asymptomatic with no symptoms at all. The first presentation may be with hip fractures or acute or chronic back pain. This is usually occurs due to vertebral fractures, compression fractures, or wedging of the vertebra. This will cause a secondary back pain. So as we said, the first presentation may be a traumatic or low impact fractures even with no trauma. And the most common fractures are the hip fracture is the main clinical consequences of osteoporosis. Hip fracture, especially fracture of the neck of the femur. One of the most important clinical features of osteoporosis is the spinal osteoporosis, which affecting the spine. No early warning symptoms, as we said, because it's asymptomatic. The patient may be presented with height loss with advancing age. This is due to vertebral wedging and collapse due to compression fractures, and the patient will show a dorsal kyphosis and the weak or protuberant or lax lower abdominal muscles with easy early satiety and bloating and nausea. Due to this kyphosis, the patient may experience a pain, either acute or chronic pain. The acute may be due to burst fractures involving the posterior cortex, paraspinal muscle pain due to stress and straining of the muscles due to affection of the spine, and if this will lead to compression or neuroforaminal stenosis and compression of the nerve roots arising from the neural foramens, this will lead to neurologic deficiencies and neurological manifestations and leg pain. And if affecting the dorsal vertebra, it may lead to restrictive lung disease. Also, this may be due to the kyphosis and the abnormal attitude of the patient. Here the picture of the x-ray of and diagram of the fractures of the vertebra, and we can see with the arrow this is the wedged part of the vertebra with anterior wedging and the fracture in the anterior part of the body of the vertebra. How can we diagnose osteoporosis? To diagnose osteoporosis, you must measure the bone density. Can we measure bone density with the conventional X-ray? No, because X-ray does not recognize osteoporosis until around 25 to 30% of the bone density has been lost. So it may give a clue for further evaluation. We have thumb rarefaction in the X-ray. This gives me a clue to do further investigation and evaluation. And however, it can be helpful for the diagnosis of the fractures which occurs secondary to osteoporosis. So, what is the best method to diagnose osteoporosis or to measure the bone mineral density? It's DEXA. What's DEXA? DEXA is a dual energy X-ray absorptiometry. Two photons are emitted from an X-ray tube and gives very precise measurements at clinically important sites with minimal radiation, which are three important sites: the lumbar vertebra from lumbar 2 to lumbar 4, the hip area around the head and neck of the femur, and the distal forearm and the lower distal radius and ulna. Measurement using two scores, which is T-score and the Z-score. DEXA scan measures, as we said, the bone mineral density of the spine from lumbar 2 to lumbar 4 and the hip and the distal forearm at the distal forearm. Who should do this or perform this DEXA scanning? All women at the age of 65 and older, postmenopausal women under the age of 65 but with one or more of the risk factors we mentioned before besides menopause. So they are postmenopausal and have another one or more of the another risk factors. Postmenopausal women who had previous fractures, women considering therapy for osteoporosis to confirm the diagnosis and to start the treatment for osteoporosis, and women on hormone replacement therapy for prolonged period should searching for osteoporosis and the medical conditions associated with bone loss. For example, if you have a patient with rheumatoid arthritis, and medications causing bone loss, as we said, especially the corticosteroids. So patients on corticosteroids for longer periods should be screened for osteoporosis using the DEXA. Here is the picture of the machine for performing the DEXA scan, and the patient lie on the examining table. It will take about 5 minutes to be performed. How can we measure for the bone density? Bone mineral density is compared by in comparison to two norms, either to young normal, which is the T-score, compares bone mineral density to optimum or peak density for a 30-year-old healthy adult of the same sex, while the Z-score is the age matching, compares bone mineral density to what's expected in someone of the same age, sex, and body size, which is sometimes confusing. The difference between patients' bone mineral density and that of a healthy young adult is referred to as a standard deviation. So the standard deviation is the unit how much the patient's measured bone mineral density is away or is near the how much units is away or near to the reference bone mineral density measured. And here is the picture of the DEXA and the report of the DEXA image. How can we interpret for the DEXA scanning? The WHO classification for osteoporosis is based on the bone mineral density. Normal values within one standard deviation of the mean level for a young adult reference population. That's referred to T-score at -1 or above. So this is normal. T-score at -1 or above. Low bone mass or osteopenia between 1 and 2.5 standard deviation below that of the mean value for a young adult reference population. That is referred to or expressed as T-score between -1 and -2.5. Osteoporosis is 2.5 standard deviation or more below that of the mean level for a young adult reference population and expressed as T-score at or below minus 2.5. Severe or established osteoporosis means 2.5 standard deviation or more below that of the mean level for a young adult reference population, and it is expressed as T-score at or below minus 2.5 with one or more fractures. So again, T-score at minus 1 or above, so it's normal. T-score between minus 1 and minus 2.5 is osteopenia. This means low bone mass, but it's not yet become osteoporosis. T-score below minus 2.5 is osteoporosis. T-score below minus 2.5 with one or more fractures, it's severe osteoporosis. This is T-score we usually use in clinical situation, but however some experts can use Z-score of less than minus 2 to view for secondary causes of osteoporosis, or in patients, in young female patients, to assess for peak bone density. What are the uses of DEXA scan? First, to detect the risk of bone fractures with those with low bone mineral density, to confirm diagnosis of osteoporosis in those with fractures, or to determine the rate of bone loss or determine the response to therapy. In this situation, usually use or comparing the reports from the same machines, because some machines may differ from the other. So it's better for follow-up or for monitoring the response to therapy, or to detect the rate of bone loss among time using the same machine. T-score is used in most postmenopausal women and men, and used to determine if the patient has osteoporosis and whether treatment is required or not, while the score, as we said before, may be used in premenopausal women. If DEXA is not available, we can do what's called quantitative CT scan, measurement of the bone density using the CT scan. It's not routine and not commonly used, because the gold standard for diagnosis and assessment of bone mineral density is DEXA. When can we use the vertebral imaging? Consider vertebral imaging tests for all women above 70 years old or older, and men aged 80 years or older. If bone mineral density T-score at the spine, total hip or femoral neck is equals or less than minus 1, and women less than that age about 68 to less than 70, and men aged from 70 to less than 80. If bone mineral density T-score is less or less than equals or less than minus 1.5, and in postmenopausal women and men aged 50 years and older with specific risk factors like the history of fractures, previous fractures, the historical height loss of 1.5 or inches or 4 centimeters or more, or prospective height loss of more than 2 centimeters, or recent ongoing of long-term glucocorticoid treatment. However, again, the gold standard for diagnosing osteoporosis is DEXA. The other investigations we can do to diagnose or to follow up the osteoporotic patients, we have the standard laboratory tests. This is not conclusive, and they cannot diagnose osteoporosis, but however they can give us a clue for the follow-up of the patients and for the detection of the secondary causes of osteoporosis, like the CMP, which is a comprehensive metabolic pattern, measure the blood levels of urea, nitrogen, calcium, carbon dioxide, chloride, sodium, creatinine, total bilirubin and total proteins and liver enzymes. We assess creatinine for the renal functions, for the choice of the treatment, because some treatments cannot be given with low glomerular filtration rates. We assess the calcium level, because if it's very low, consider and replace for deficiency of calcium, because calcium is mandatory with all types of treatment of osteoporosis. And if it's too high, consider the hyperparathyroidism. We measure the alkaline phosphatase for osteomalacia and Paget's disease. So a CMP for detecting the secondary causes of osteoporosis and for the following up, and for the choosing the options, proper option of treatment or proper drug for treatment of osteoporosis. Measuring the active vitamin D, because if it is deficient, important to replace. And also measuring calcium in urine, if there is hypercalciuria or if there is a malabsorption, it will be low. We can also measure the parathyroid hormone with calcium. If calcium is elevated, if considering using teriparatide, as we will see later, for treatment of osteoporosis. Also, we can measure the testosterone in men with osteoporosis, and also measuring the cortisol in urine. Finally, in the assessment of osteoporosis, we must assess for the future fracture risk using what's called the fracture risk assessment tool. This is a tool was developed in the last years to assess for the fracture risk in the next 10 years, utilizing many clinical and demographic data, as the current age of the patient, the gender, the body weight and height, and calculating the body mass index, and the previous history of fragile fractures or osteoporotic fractures, including the clinical and asymptomatic vertebral fractures, also the parental history of hip fractures, and the bone mineral density of the femoral neck, the previous consumption of oral glucocorticoids or current treatment with glucocorticoids of 5 or more milligrams per day of prednisone for more than 3 months forever, which is the most important to assess the steroid intake. And also the current smoking and alcohol intake, 3 units or more drinks per day, and also assess for the presence of rheumatoid arthritis and the secondary causes of osteoporosis, like diabetes mellitus, the osteogenesis imperfecta, long-standing untreated hyperthyroidism and hypogonadism, or premature menopause, chronic malnutrition or malabsorption, and chronic liver diseases. This tool will calculate the fracture risk or predict the fracture risk in the next 10 years. Here in the picture of the FRAX score calculation tool, it's an application. You just fill in the space and answer these questions, and it will calculate spontaneously the fracture risk in the next 10 years, calculating the major osteoporotic fracture risk and the hip fracture risk expressed by percentage. The threshold for treatment that needs treatment for osteoporosis is at least 3% of hip fractures and 20% of major osteoporotic fractures in the next 10 years. Finally, what's the treatment of osteoporosis and how to manage and prevent for osteoporosis? First, the main goal of treatment is to prevent or reduce falling, because the main complication of osteoporosis is pathological fractures. So how to prevent these fractures from prevent falling? Consider the occupational therapy evaluation for the home hazards that cause the patients to fall, and also minimize the medications that cause sedation and drowsiness of the patient, and he prevent him from becoming more liable to fall, and using hip protectors so that if the patient fall down, he can protect his or her bones from getting fractured. And by patient education to change lifestyles. For example, avoid smoking and excessive caffeine and alcohol intake. Take the adequate intake of calcium, at least 1,000 up to 1,500 milligram per day, and vitamin D about 1,000 international unit per day. And in some cases, we may need up to 50,000 international units per month. Encourage the physical activity, especially the weight-bearing exercise, because the non-weight-bearing exercise has no impact on the bone health, though it's important for the increasing the cardiac efficiency, but on the bone, the non-weight-bearing exercise has no effect on the bone. It's better to do the weight-bearing exercise simply like walking, running, and jogging. Treatment of osteoporosis include medical treatment, include physical treatment, and finally the surgical treatment in severe cases. Medical treatment of osteoporosis based on DEXA scanning, T-score less than minus 2.5 in postmenopausal women, and based on a FRAX score, as we said before, 10-year risk for fractures more than 3% in hip and more than 20% major osteoporotic fractures, or based on a traumatic or low trauma fractures. Again, if we diagnose osteoporosis based on DEXA or based on FRAX score or based on these symptoms like a traumatic or low trauma fractures, so the patient should take medical treatment for osteoporosis. Osteopenia or osteoporosis plus steroid treatment or anti-estrogen or testosterone therapy. And third, osteopenia and high risk for fracture on individual basis to decide whether the treatment should be given or not. So it is given in osteoporosis, osteopenia, but with high risk patients on steroid or hormonal treatment, and in individual basis according to the assessment of the patient. What are the medical drugs treatment options for osteoporosis? We have the bisphosphonates, which is the commonest and the most important one and more widely used. We have the denosumab or Prolia, the teriparatide or Forteo, and the selective estrogen receptor modulators, and the hormone replacement therapy, and finally the calcium, which is not commonly used nowadays. We can classify them into bone resorption inhibiting agents, that's anti-resorptive drugs. It inhibit the resorption of the bone, and the bone forming or stimulating agents that it help in new bone formation. We have the anti-resorptive drugs like the bisphosphonates, the denosumab, the hormone replacement therapies, oral estrogen or raloxifene, and the calcitonin. And we have, on the other hand, the bone forming or the bone stimulating drugs, mainly the parathyroid hormone or teriparatide and the growth hormones. And in the medical treatment, we have the anti-resorptive, we have the bone forming drugs, and we have the NSAIDs or analgesics like acetaminophen or NSAIDs to control pain of vertebral fracture. That's the medical treatment for osteoporosis. To discuss with more details, bisphosphonates are generally the first line for treatment of osteoporosis. We have many preparations of bisphosphonates like alendronate, risedronate, zoledronic acid, and ibendronate. They suppress the resorption of bone by preventing osteoclast attachment to bone matrix, so they are anti-resorptive drugs as we said. But they cannot be used with glomerular filtration rate less than 30 to 35%. So if you have a patient with impaired renal function, you should not prescribe bisphosphonates and shift to another drug. They decrease vertebral and non-vertebral fractures in most patients. The main side effects for bisphosphonates is esophagitis, causing avascular necrosis of the jaw, and some atypical fragility fractures and delaying the fracture healing because they are not tolerable for the GIT system. They may cause esophagitis, so they are better given in upright position before breakfast or in the middle of a 4-hour fast, and waiting for at least half an hour or hour before eating after taking or administration of the drug to avoid this esophagitis and to avoid the GIT irritation. These are preparations of the bisphosphonates. We have the alendronate once daily or a weekly dose, and also risdronate can be given once daily or a weekly dose, while ibandronate can be given in a monthly dose, yani once per month, while alendronate can be given once per week, and the risdronate can be given once per week. And we have the injectable form of the bisphosphonate, which is the zoledronic acid, and it's a cluster. It's given in a single 5 milligram infusion, given intravenous over more than 15 minutes once per year. So it's a drug given once per year, one dose per year. Should still supplemented with calcium and vitamin D, all bisphosphonates and all osteoporotic drugs. We should give with them the calcium and vitamin D to maintain the normal level with all therapies of osteoporosis. May be ideal for those with GIT contraindications. As we said it before, the oral forms of bisphosphonates can cause GIT complications. So those with GIT contraindications, it's ideal to give them zoledronic acid intravenous infusion. And the glomerular filtration rate should be more than 30, as we said before, with all bisphosphonates. The second drug, we have the denosumab or Prolia. It's a humanized monoclonal antibody to the rank ligand. As we see in this picture, the osteoclast precursor have the rank on its surface, and to be functioning, this rank must be fused with its ligand, which is the rank L. The humanized monoclonal antibody, which is the denosumab, will combine or fuse to this rank L, preventing it from fusing to the rank which is present on the surface of the pre-fusion osteoclast, and thus preventing the osteoclast from being activated and prevent the osteoclast formation. Thus, the osteoclast function and survival will be inhibited, and thus it will not be able to resorb the bone. So it's anti-resorptive drug by combining to the rank L, preventing it from fusing or activating the osteoclast to become a mature and functioning osteoclast. Thus inhibit the bone resorption. It's given a dose of 60 milligram subcutaneous injection every 6 months. It has a shorter biological half-life than the bisphosphonates. As we said, the bisphosphonates can last for 1 year, and reduces vertebral and hip fractures as well. Given, as we said, in a dose of 60 milligram subcutaneous injection once every 6 months. It is prescribed for postmenopausal women with osteoporosis and approved for women receiving aromatase inhibitors and men receiving the gonadotropin reducing treatment. It's contraindicated in cases of current hypocalcemia because it will produce also hypocalcemia in pregnancy and in hypersensitivity. The most important and potential adverse effects are the atypical fragility fractures, avascular necrosis of the jaw. It may induce possible increased risk of infections like cellulitis or endocarditis, and suppression of bone turnover. Third, we have the selective estrogen receptor molecules, which are mixed agonist and antagonist of specific estrogen receptors like the raloxifene, which have effect on decreasing vertebral fractures but no effect on non-vertebral fractures. It also decreases the risk for breast cancer because it's a synthetic engine having an estrogen-like action on the bone and lipids, but without the effect on the breast and endometrial tissues. So it will have a less risk for breast cancer. The main adverse effects is thrombotic events, maybe venous thrombosis or coronary artery diseases. May cause hot flashes and leg cramps. It's suitable for women under 50-year-old who have undergone an early menopause. Hormone replacement therapy, like estrogen without progesterones, was once considered to be primary therapy of osteoporosis prevention and treatment. It blocks cytokine signaling to the osteoclast, and it induces reduction of the hip fracture and vertebral fractures. But however, the main side effect is increased risk of breast cancer, cardiovascular diseases, thrombosis, and it's not currently, the hormone replacement therapy is not currently used to treat or prevent the osteoporosis alone, often indicated for severe postmenopausal symptoms to control the climacteric symptoms in women under 50 years who had gone an early menopause. That's the anti-resorptive drugs. Let's move to the bone-forming drugs on bone-stimulating drugs, mainly the teriparatide or parathyroid hormone or Forteo. It stimulates the bone remodeling by increasing bone formation. It's indicated in moderate to severe osteoporosis, and it reduces fractures, mainly vertebral and non-vertebral fractures as well. However, the main side effect is that high doses in rats caused osteosarcoma, but no cases reported in humans who received the drugs. So it should not be given for more than 2 years, maximum 2 years. The main side effect is mild hypercalcemia between 10.5 to 11 milligram. It's expensive, and it is taken subcutaneously, subcutaneous administration by daily dose. Should not be given in patients with hypercalcemia with multiple myeloma, bone metastasis, of course, or skeletal tumors, or the children, teenagers with growing bone. So because we are afraid from the osteosarcoma, so it's not given for more than 2 years. It's given in a 20 milligram subcutaneous injection for maximum 2 years. So we said before, treatment of osteoporosis include the medical treatment, prevention of the falls, and we have the rehabilitation. Rehabilitation include bracing for the vertebral fractures in cases of acute pain to produce immobility to lessen the bed rest duration, and in cases of chronic pain to substitute or support the weak muscle and decrease the ligament strain and perform protection for the spine and the bones from more fractures. And in certain sports and recreational activities, if your patient wants to do some exercises and some recreational activity, he should wear these vertebral orthoses to protect against any undesired fractures or strains or sprains. Types of bracing or vertebral bracing: we have simple elastic binder, and we had heat moldable thoracolumbar jacket, and we have the hyperextension thoracolumbar orthosis, which keeps the spine in the hyperextension state or attitude to guard against kyphosis, which is very common in osteoporotic patients. And finally, we have the custom molded plastic body jacket, which is tailored to the patient's body. So we have the ortho. Finally, we have the occupational therapy. Occupational therapy means that we do home modification to reduce the risk of falling. We rearrange the materials and utensils inside the home to make a healthy environment around the patient to reduce the risk of fall, prevent the falling of the patients. Like what? Like removing through rugs, using non-skid tape of different colors on the outer edges of the step, or use ramps instead of the stairs, like using handrails and lightening dark hallways and bathrooms, modifying or remove the pass tubes to avoid stepping over the edge of the tube and bending. This is in the home environment, and in the work environment we can do work simplification to reduce vertebral comprehensive forces, like what? Like repositioning of the desk's files to avoid the trunk flexion, and to use wheeled office chair. We can use also long handled reachers and wheeled carts of proper height to decrease the vertebral strain. We can use electric can openers, knives, and mixers to make the kitchen tasks more easier. Finally, and the last, we have the surgical treatment for the severe cases of osteoporosis, indicated in cases of progressive painful deformity of kyphoscoliosis, or if there is a neurological deficiency due to compression of the nerve roots, and if there is instability of the spine. We can do what? We can do vertebral fixation, fix more than one vertebra together, prevent moving, or vertebroplasty. That's all, and thank you.